Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Hi, Mars. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let me know if you want me to sing a song. Okay, we are at 2 o'clock. Welcome to our PETOS presentation. We are excited to have Dr. Hallie Keller with us today. She's an attending at Primary Children's in the emergency room. I've worked with her for a very long time. She's an exceptional doc, and I'm always happy to see when she is on. She's going to talk to us today about lightning strikes. Just an FYI, we've had a request that our quiz questions be sent out quicker so that the presentation is fresh in your mind. So we will be doing that. If you email me after you've watched this presentation today or any time today, I will have those quiz questions to you by tomorrow. And then we'll try to get those out sooner as well. We are working on getting a microphone for our questions in the room. So stand by for that as well. Remember that we can live chat and you can send in questions to me. I'll be monitoring that. So we'll turn it over to Dr. Hallie Keller.
Okay, thank you. So yes, I'm Hallie Keller. I'm an emergency medicine physician at Primary Children's. I'm also medical director for LifeFlight Children's Services, so over pediatrics and neonatal teams with LifeFlight as well. And today I've been asked to talk about lightning and also some electrical injuries. Certainly there's some pediatric things to this topic, although a lot of it applies to the adult world too, but we'll talk. I don't have any financial relationships with any medical product, nothing to disclose here. So the objectives today of this talk, one, to review briefly physics, not a physicist, but review our physics of electrical injuries. Two, understand mechanisms of injury in electrical injury. And three, discuss aspects of electrical and lightning injury pertinent to transport medicine. Okay, so there are different types of electrical injuries, but in general, they're common. They're often accidental and most often preventable. There tends to be a bimodal distribution of environmental electrical injuries, so children and teenagers make up a large portion of these accidents, and then work-related in adults. Young children tend to have electrical cord or outlet injuries, and adolescents tend to have the high voltage injuries from climbing trees, from climbing power lines and things like that. There's a 2-to-1 male to female ratio in kids, 90% male in adults. That makes sense because they're work-related injuries. Work-related. So greater than 50% of lightning injuries occur during outdoor recreational activities. And again, a really large percentage of these are children. Tend to be outside, playing, having fun, doing recreational kind of stuff. So what are the mechanisms of injury for electrical injury? Well, there are several. One is the direct effect of electrical current. Another is conversion of that electrical injury to thermal injury, and then blunt mechanical trauma. So from either a lightning strike and its shock wave, or a muscle contraction from a high voltage injury or a fall. So certainly blunt trauma is an injury mechanism there as well. So the nature and the severity of the electrical burn are directly proportional to the current strength and to the duration of the current flow. So here's where we're going to do just a little bit of high school physics, right? So the extent of injury depends on the voltage, the resistance, and the type of current, whether it's AC or DC, and the current pathway, as well as how long you're contacting that pathway. Remembering that electricity is the flow of electrons between points of high concentration to points of lower concentration, so that's the potential. And current, I, is the volume of electrons that flow between these points, measured per second. Voltage is the force that drives the electrons across that potential difference, and resistance describes the hindrance to flow. So Ohm's law, again from high school, I equals V over R. So in other words, the current is inversely proportional to resistance. You have a lower resistance, you're going to have a higher current. And the current is directly proportional to voltage, so a higher voltage and a higher current. That will show you how that's important. Okay, so the amount of current flowing through the body determines the injury. Tissues that have higher resistance, like skin and bone and fat, tend to heat up and coagulate. So we see bony injuries and periosteal burns and injuries because of the high heat there. Lower resistance tissues, such as nerves and blood vessels, tend to transmit the current. And then, of course, dry skin has a much lower resistance than wet skin, but even a small voltage applied to wet skin, like a mouth of a child, can generate much more current, so the injury pattern tends to be more severe. Okay, I think this is the last physics slide. Okay, alternating current, direction of the flow of electrons changes on a cyclical basis, and that's just our, as we all know, standard household current, alternating at 60 cycles per second. And then direct current, the direction of the flow remains constant, and that's in batteries or railway tracks or our vehicles' electrical systems. DC current, also in power lines and voltage things, can cause a single muscle spasm, and that throws the victim from the source. They have a very short duration of exposure to a very high voltage, but a very high likelihood of trauma because of that likelihood of getting thrown. Alternating current repetitively stimulates muscle contraction, so especially with hand injuries, you'll see that the flexors of the hands are stronger than the extensors, and so they tend to have a longer exposure to the source of the electrical injury because they hold on with your flexor muscles. So then you can, even though it's AC and not DC, get a longer exposure to the electrical source. Okay, so high voltage is greater than 1,000 volts. Power lines are 100,000 volts. Lightning voltages that we'll talk about in a bit, voltages are excess of 10 million volts. And then, of course, low voltage is less than that. Okay, so here's where it matters to first responders and EMS people. What is this going to happen? What is that type of current going to do in terms of arrhythmia? Lightning is typically taught that you have asystole with a lightning strike, although they've had various studies and they have found people in VTAC and VFib as the initial rhythm as well. DC tends to be VFib, and alternating current also is VFib, but lightning is classically asystole. And then, of course, the pathway of the electrical current determines any injury pattern. So if you're hit or in the thorax, you're more likely to have an arrhythmia. If you're hit in the head, you're more likely to have problems with respiratory arrest, central nervous system issues, seizures, and paralysis. And again, feel free to stop me at any time or ask questions. Okay, so just to briefly talk about this electrical injury, you all probably encounter patients of fair enough who've been tased. So this is something that we'll talk about briefly. So electrical weapons deliver bursts of high voltage, low amperage direct current. And there have been studies done looking at a large amount of patients who've been tased, and there's no evidence of any lab abnormalities, cardiac ischemia, or arrhythmias in patients who've had 15 seconds or less exposure. And they actually did a pediatric study looking at 100 patients. The median age was 16, so adolescent pediatric patients for the most part, and they had no significant injuries. But in rare instances, fatal arrhythmias have been observed. Of course, intoxication with stimulants increases the risk of fatal arrhythmias, so PCP, cocaine, methamphetamines. Intoxicated patients who get tased are more likely to have arrhythmias. And less important to pediatrics, patients with cardiovascular disease, of course, are more likely to have arrhythmias when tased. And then the last thing is an injury if you fall after being stunned. And that, yes, is actually a pediatric patient. That was one of my patients. One of my first tased patients in the ER. He was 14. He was a big 14. And the officer brought him in, and I said, okay, well, are you going to take those out? And he said, no, I put them in, you take them out. I mean, you can see the barb there on it. Ouch. The next type of injury, this tends to be adolescents in terms of climbing, power lines, things like that. Little kids like to climb too, but it tends to be teenagers that do the high trees and the power lines. This is an example of a high voltage burn. So again, a 14-year-old climbed up an electrical pole. That's just the skin findings on this patient. Again, significant trauma from being thrown from the source, blunt head and torso injury, acute hypotension, so this is particularly pertinent to transport. So if you have acute hypotension, certainly important to think about intra-abdominal bleeding and fluid resuscitate these patients. Spinal injuries, so immobilization of your patients, and then monitor them closely for any kind of arrhythmia because they're certainly at risk for arrhythmias, especially when in that first hour after injury. And then remember that the external burns don't necessarily reflect the degree of internal injury. It's very hard to predict how severely they may have internal injuries or muscle necrosis or other issues like that based on their external findings. And these patients may require pretty aggressive IV fluid resuscitation. Don't have to hesitate doing that en route as well. So this is at least classic for pediatric electrical injuries. Little children contacting electrical cords or outlets. Most typically, it's putting their mouth to the female end of a extension cord or biting a live wire. And of course, that's where they have the decreased resistance because their skin is wet and tend to have more significant tissue injury. So that low voltage applied to the tissue generates much more current and can create significant issues. And also labial artery bleeding is kind of classic, and you can see why there, especially when that scab falls off. We're going to move on to lightning issues or lightning injuries. Any specific questions so far? Yeah. You know, it's really not predictable. So even with lightning, you can have entry and exit, but you can't necessarily find it, and you can't really predict the path, because it can kind of go in anywhere and out anywhere. We'll talk about that a little bit. With lightning and with electrical injuries, it's harder. It's harder than, say, a gunshot wound, figuring out where the entrance is and where the exit is and really determining the path, especially in lightning injuries. You know. Yeah, so, I mean, certainly from an EMS point of view, I mean, your issues are going to be arrhythmia, 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 right? And then, of course, ABCs, because these patients, I think that's going to be the biggest thing in terms of instability. And then burns and fluid resuscitation or hypotension related to trauma, et cetera. But yes, eventually they should get a complete once-over to make sure we see the extent of the burn. I'll show some examples of those too. But it's really unreliable, the entrance and the exit wounds in a lot of electrical injuries. You know, oh, sorry, thank you for having me repeat. So the question was, children biting electrical cords, how common is it to have arrhythmias? Not as common as with the higher voltage injuries, but it can happen. They're not super common injuries, but it's certainly something that's worth, I'd put them on a monitor when you're transporting a child like that. And mostly because it's difficult to know the path of the injury, but less likely. You know, I haven't personally, Hillary, I don't know. Electrical, we see thermal burns all the time in our pediatric patients in the emergency department. I mean, kids, you know, putting their hands up on fireplaces and being toddlers and they can't lean away, or falling into fires, all sorts of things like that. We see electrical burns less frequently. So, you know, I don't know that I see a whole lot of that. I know myself as a 16-year-old, I was talking on a cord phone. You know how we had those corded phones, and I put my hand on top of a toaster that was plugged in but not on, and I think my hand was wet, and it completed a circuit. It was really kind of interesting because it was exactly what they talk about with the alternating current, and you get flexion of those muscles, and I couldn't pull my hand off of the toaster because I completed a circuit, and I had like full thickness burns, you know, of my fingers, and they were worried about arrhythmias, but I never did. So, I mean, I think they're just more rare in general in pediatric patients. We see less electric. Yeah. Tongues and outlets. I've seen a tongue, pretty bad oral injury from a tongue in an outlet. Don't try that one, Tia. Okay. Yeah. So for lightning injuries, most fatal arrhythmias are within the first hour. They will watch them for days. In fact, if you read case reports on lightning injuries, and we'll talk a little bit more about this. Shoot, I forgot to repeat the question. The question was, how long are you going to be worried about arrhythmias after an electrical injury? And so for lightning injuries, the fatal ones are within the first hour usually. So it really matters to people transporting these patients. But they'll monitor them for days. In fact, there can be enough myocardial insult, and I'll have a slide that talks about all the different ways lightning can injure the heart muscle. And so these people can develop arrhythmias days out even. But really the fatal arrhythmias are within the first hour, and oftentimes when you encounter the patient. So a first responder encountering a patient, an arrhythmia, if you have a down patient, arrhythmia is like high up there. We'll talk about it. Really that first hour. Okay, so this is one of my favorite cartoons because I was out running with a friend and there was like this huge lightning storm and I was like, hey, we need to go inside. And she said, no, like people don't die from lightning. Like, let's just keep going. And this is exactly it. So there are two little guys down there and one of them says, whoa, we should get inside. And the other one says, it's okay. Lightning only kills about 45 Americans a year, so the chances of dying are only 1 in 7 million. Let's go on. The annual death rate among people who know this statistic is 1 in 6. So it's just to be careful about what you do with your statistics and how you interpret statistics. Okay. So lightning strikes during thunderstorms kill more Americans each year than hurricanes or tornadoes. Contrary to the saying, lightning can and often does strike in the same place twice. Lightning incidents often involve more than one victim. And then ground current can actually spread the electricity to a group of people all seeking shelter. And so in a third of strikes, you're going to have more than one person involved. This was just 2 days ago. My friends on Facebook who all live in Washington were like, wow, I cannot believe this. And then CNN said like 1,200 lightning strikes in a 3-hour period in the Seattle area. It was pretty impressive. So lightning injuries are responsible for about 300 injuries and about 100 deaths per year. They think that's actually an underestimate because some people actually don't seek care because they're okay after they get hit. But 10 to 30% of those struck by lightning actually die. 75% of survivors have some sort of permanent disability, and those range from minor disabilities to pretty severe. We'll talk about those. Most lightning-associated deaths occur within 1 hour from injury, and that's either fatal arrhythmia or respiratory arrest. So the reason I'm giving this talk is because our LifeFlight team transported 4 pediatric lightning strike victims in a 2-week period in the summer of 2017. And so we had all these people saying, wow, I wasn't sure about this and I didn't know about this. And so that's kind of when I first gave this talk. So I'll tell you about a couple of our cases here. In the Uintas, there were 3 girls, sisters ages 2, 7, and 8, and they were camping in the Uinta Mountains, and they took shelter under some trees for a quickly moving storm. And 2 of the 3 were unresponsive, and Dad came on the scene and actually started CPR on his kids. And then within a couple-week period of time, there was this lightning strike in southern Utah. 2 girls who were aged 8 and 16 were hiking in Beaver County and both hit by a lightning strike as well. So that was like the Uinta Mountains, I think a week before this had happened. I had been up there camping with my kids. It's a beautiful place to be, but you can see there's really no place to take shelter. And this is interesting because this shows, and this was a news report right after these lightning strikes in southern Utah. And so basically these girls were hiking out here where there was no rain. So all this color is the precipitation. And so there was no rain and the lightning was all down here. And there was just this random stray piece of lightning. They didn't even know there was a storm. It's interesting because that's what hit them. And the older girl said she remembered just hearing thunder. And then the next thing she knew, she woke up, but she was just laying on the ground, and she turned around and the smaller child that was with her was unresponsive. So this is just gonna, oh, and then the other thing, sorry, I don't have don't have my presenter view showing, so I can't tell you all of my notes. But the other thing that was interesting, so the younger child was actually intubated on scene by EMS. She had a GCS of 15, I think, on their arrival, and both children survived. So here are a couple of our patients in their hospital course. So one patient, patient A, had mild increased CK, which is just muscle injury, had some ferning pattern seen on her skin, which is specific for lightning injury, and I'll show you some pictures of that as well. Had a left ankle burn and really a largely uneventful hospital course. And then patient B had severe traumatic brain injury with intraventricular hemorrhage. She had punctate hemorrhages of her left temporal lobe, the right parietal lobe, and the caudate area. She had bilateral pulmonary hemorrhages. She had pretty significant bowel injury, kind of like shock bowel, with mesenteric edema, bowel wall thickening, and some periportal edema. They weren't really sure whether that was related to the lightning strike itself, or did she have a period of arrhythmia and hypotension, and so it was shock bowel from that. Not clear. She had retinal hemorrhages. She had profound hearing loss in the right ear and moderate to severe of the left, and then burns of her chest, back, buttocks, and perineal area. She had a 5+ week course in the hospital, and pretty profound lasting injuries where patient A just kind of walked away. So lightning injury is caused by a unidirectional massive current. It's similar to direct current, although people won't say it's really a DC. It lasts very, very short, so 1/10 to 1/1000th of a second, but the voltages exceed 10 million volts. Temperatures are super, super high, so 5 times hotter than the sun, but very quickly. And then the rapid heating of the surrounding air generates a shock wave, and that shock wave can cause mechanical trauma to the body. Very difficult, as we talked about before, to predict the course of the current flow and the extent of injury, even just based on external findings. It can be really difficult. And remember that surface findings grossly underestimate how much tissue damage there is internally. So, and again, this kind of alludes to, it's hard to tell exactly what happened with the lightning strikes, but direct strikes, they can enter through eyes, ears, mouth, and flow internally. We talked about the different places on the body that electrical injuries can hit and then the resulting effects. You can also have a lightning injury from touching a metal object, and then that metal object is hit by lightning. So that's a contact. There's also side flash or splash, where lightning actually jumps from its primary strike object, like it hit the tree, and then jumped to the kids nearby, to an object or person on the ground. Ground current or step voltage is electrical potential that spreads between a person's feet, so the electricity actually travels easier through a human or through a body than it does through the ground. So that has been responsible for killing like large numbers of cattle, because their feet are spread apart, and so it increases the current through them. And so cattle have died from what they think is ground current or step voltage. And of course, blunt trauma from a shock wave. Cardiac involvement, again, really important to EMS people, and important to understand all the different ways that it can affect the heart. So a massive direct current shock can depolarize the entire myocardium, which is kind of why the asystole is pretty typically taught. And you can actually get spontaneous resolution of that asystole, and the heart can start again. Sometimes. Autonomic stimulation and a catecholamine surge can also make arrhythmias worse. There have been VFib and VTAC on arrival on a scene with a down patient, and also evidence of QT prolongation. Like I said before, spontaneous return of sinus rhythm has been noted after asystole. Part of the problem is respiratory paralysis may actually last longer than the cardiac arrhythmias, and so you can get hypoxia causing degeneration into a VFib. So nobody really knows, did they initially have asystole, but then they were paralyzed and didn't breathe, and it turned into a VFib kind of arrest. So who knows what you're going to find when you get there. But it emphasizes the importance of breathing for these patients also, because you have a heart rate, but respiratory paralysis can be as big a problem. And again, this is the slide I talked about that will just show some of these cardiac effects. So So you can have here the arrhythmias specifically. You can have aortic injury or dissection, myocardial ischemia and infarction because of vasospasm or vascular injury, a contusion to the myocardium or pericardial injury. And then all of these things contribute to later onset injuries like ventricular failure and myocardial stunning kind of things. So. Okay. Now you're getting your quiz early. I didn't know about this quiz, but here they have a quiz early to you. In lightning strikes with multiple casualties, treat the patients without signs of life first. True or false? Votes for true? Anyone vote for false? True. So this is reverse triage. It's kind of interesting. So lightning strike victims who do not sustain cardiac arrest generally will survive without intervention. They may have lots of problems, but they will generally survive. So it's reverse triage priorities. Treat patients in arrest first. Good outcomes have been described even among patients with asystole, and they recommend prolonged CPR with asystole, even if you have asystole as the initial rhythm, because they've had good outcomes in these patients. And remembering that patients can have spontaneous cardiac activity, but prolonged paralysis of the respiratory muscles, so bag mask ventilation is huge. And remember that most lightning strike deaths occur within the first hour. Okay. Other organ involvement in lightning injury, damage, I think I just lost that. Damage to the central nervous system, the peripheral nervous system, loss of consciousness, respiratory arrest, autonomic dysfunction. There's something called coronoparalysis, and I may not even be pronouncing that correctly, but it's a specific injury due to, with lightning injuries where you get blue, mottled, and paralyzed extremities, usually lower extremities more than upper extremities, and it's thought to be due to vascular spasm from lightning strike. Hypoxic encephalopathy, hemorrhages, infarctions, spinal fractures. So certainly important to immobilize these patients. Ruptured TMs, optic nerve injuries, cataracts, things like that. Okay, ready? Here we go again. True or false? In lightning injury, fixed and dilated pupils are an indication that an EMS provider should stop resuscitative efforts. True? Yeah, that's false. Lightning injury can cause fixed and dilated or asymmetric pupils as a result of autonomic dysfunction. It may be completely unrelated to a brain injury. So it is not a reason to stop resuscitation. In fact, they've had description of prolonged resuscitations with people who have fixed and dilated pupils. So it doesn't necessarily reflect brain injury. However, of course, lightning strikes can cause all sorts of brain damage and things like that. So looked into further, obviously, in the hospital. Good. All right, this is some of the interesting stuff in terms of just skin findings. So skin in lightning injury, superficial burns are really common, like more than 85% of patients will have them. Deep burns, unlike in our power lines and high voltage, you saw those pretty deep burns in that picture, deep burns are pretty uncommon. So the low incidence of deep burns is because it's such a short duration of contact. And also you get a flash over effect when the current travels on the skin surface and is discharged to the ground. So it's a feather or a fern. Punctate burns are little small cigarette circular burns, and I'll show you pictures of those. Linear burns occur pretty frequently, and that's where sweat or water accumulates on the skin and then is vaporized when it gets heated up by the lightning. Those can be partial thickness burns usually. And then, of course, burns from where metal objects were touching the skin. So like belt buckles, you'll see a thermal burn from heating up from the lightning, and you'll see a belt buckle impression on skins, things like that. So this is the ferning, pretty pathognomonic for lightning injuries. This only lasts about 24 hours, but you see this and you know that your patient has been hit by lightning because nothing else causes it. It's not actually a burn. There's no damage to the epidermis or to the dermis, but it has to do with electrons really extravasating some of the blood into your subcutaneous tissues. And again, it only lasts for about 24 hours, and there's no scarring or damage or anything like that, but it's pretty impressive and relatively common. pulled some of these pictures from an Atlas of Emergency Medicine. I have a couple that we were given permission to use from our patient at Primaries. These are the punctate burns. These are thought to be due, nobody really knows, but these are thought to be due from internal current coming out through the skin. These tend to be partial thickness or even full thickness, but pretty small, but they're almost like little puncture circular lesions. Veneer burns, pretty common. Again, this is, you can see the areas where they may have had more sweat or water on the body there and causing those partial thickness burns. This was our patient, so you can see how she has a lot of those linear burns, and they're mostly partial thickness, but right down here where you can see fluid vaporized when she was hit. That was on her chest as well. Can be pretty extensive. Other organ involvement, renal, actually pretty uncommon in lightning injury. Musculoskeletal, you can have muscle paralysis, especially important for, we talked about the lower extremity paralysis can happen. Any trauma from any type of muscle contraction or a fall. Vascular injuries like coagulation of vessels or delayed aneurysm formation, myocardial infarction can occur, and that can occur later usually. All right, last true or false. Parkland or similar formula should be used for fluid resuscitation in patients with lightning injuries. Anyone for true? Anyone for false? False. We talked about this a little bit before. The Parkland formula should not be used in lightning burns because surface burns and electrical injuries in general grossly underestimates the extent of the internal injury. And certainly aggressive fluid resuscitation, if there's any evidence of muscle necrosis or if you are struggling with patient's vital signs, you're fine and should be doing aggressive fluid resuscitation. Okay, and I think we've talked about most of this. Lightning injuries actually usually require less than other electrical burns or thermal injuries. High voltage tend to have pretty extensive injuries internally, but lightning, it's just such a short exposure. Avoid IV fluids with potassium due to risk of hyperkalemia and muscle injury. Remembering that hypotension should really prompt a search for thoracic or intra-abdominal bleeding for blunt trauma, and don't hesitate to fluid resuscitate. About those things. So I thought I made it longer, but I didn't make it longer. I apparently talked too fast. Okay, so in summary, electrical weapons are relatively safe. Younger pediatric patients are more likely to be injured from electrical cords and outlets. High voltage injuries more in teenagers or from work-related incidents. High likelihood of trauma, arrhythmia, burn. We talked about intra-abdominal hemorrhage. We've talked about the importance of fluid resuscitation and monitoring your patients for arrhythmias. Lightning injuries, cardiac arrhythmias, and respiratory arrest are the most common causes of death, certainly something that we can do something about as EMS people. Reverse triage in the setting of multiple victims. Victims who are responsive on scene are most likely going to survive, so let them be and move to the others first. Prolonged CPR may be indicated even with initial asystole or fixed and dilated pupils. Fluid resuscitate the patient. You what? Oh yeah, thank you. Okay, so the question was burn patients. If this is a child that you're transporting, should it go to a burn center or to a children's hospital? I would say in general with electrical injuries, they're going to go to the pediatric facility first because of such a high concern for blunt trauma kind of things, falls, and multi-system organ injury. Thermal burns, when they're pretty extensive, as you know, we often send those directly to the burn center. But oftentimes these injuries, the burns on the outside are less impressive, and the trauma may be more of an issue. So I would say in general, these patients should go to a pediatric trauma center first. Would you agree, Hillary? That's a good question. Thank you. And could everyone hear Hillary's response there? You want me to repeat it or no? Okay. I'll leave it be. Okay. Well, I think in summary, she was saying in general, she agreed with me that because of the high likelihood of trauma, they should come to our facility first. And it sounds like there may be some changes coming where even with thermal burns, the burn unit at the university may want some of those children to start coming for their initial resuscitation. Hillary would be more familiar. Yes. So the question was, sometimes if you have an arrest on scene, you'll stay and work it on scene. And with this type of patient, would you move the patient? So, I mean, I guess I would say this: you treat asystole the way you treat asystole, right? And you treat VFib the way you treat VFib. So I think, you know, you're going to want to treat those appropriately as you would protocol-wise. But if you can get moving, I would get moving, because these are patients that we will do prolonged resuscitation and less likely to be called on the scene, if that's what you're asking. Right. So, yeah. But I still want you to shock your rhythms and things like that. Absolutely. Definitely fussier. Oh, so that's okay. So the question is, what are the signs of muscle necrosis, and are those immediately apparent? No, probably not going to be immediately apparent from an EMS kind of standpoint. Those are things that we can figure out from a laboratory standpoint. I guess I'd say from where you're coming from, if you have a patient who's got saggy blood pressures, tachycardic, et cetera, don't hesitate to fluid resuscitate, because you can't see the injury inside, and you can't predict the injury inside based on the skin findings. That makes sense? Yeah. So the question was, it sounds like when you have a patient in asystole in the field, you sometimes shock asystole as a trial. I may let Hillary answer that question. I know that's not PALS. That's not how we treat asystole in PALS. Hillary, I don't know. Do you have thoughts on that question?
Great. Yeah, so I think if you've done high quality CPR, you have access, you have an airway, and you're getting chest rise and ventilation, and even if you're lucky enough to get end-tidal CO2, whether you have an advanced airway or not, and you feel like you have given a couple rounds of CPR with epi and you still have no return, I don't think it does any harm to try it. So, you know, same thing with this. It seems like
a pericardial thump,
right?
I mean, that's been proven
yeah.
to make a difference.
Yeah. So if it was my kid, I would want you to try anything and everything. So I think there's no harm in trying it. You know, I think you stick with PALS to start with. And if it's a kid and they don't come back with good ventilation and oxygenation, they're still in asystole, that's usually not a good predictive sign. But with this, just with knowing that some people, their hearts will start again on their own, I think it's worth a try. Start with your asystole PALS algorithm, and if no help after a few rounds of epi and CPR, give it a try.
Especially good quality CPR, though, for sure comes in. Okay. Other questions? So the question was the two children that were standing next to each other, and one had pretty extensive injuries and the other didn't have nearly as extensive injuries, but was clearly hit by lightning as well. What was the difference between the two? I don't think anybody knows. I don't think we have good enough answers to know, was she hit more directly, and was there a splash onto the other kid? I mean, I don't think anybody knows. I think it's very not predictable. That's certainly not something we study. Our question was, in terms of the literature, are you seeing more lightning strikes? It seems like we see them in the mountains and we see them on dirt. But what about water? In terms of sheer numbers, Florida is like lightning strike capital of the world. Everything I found in the literature is like Florida, Florida, Florida. So it's got to be, there's got to be some water related as well. I think it just happens to be where lightning comes up in the Uintas or in the mountains, and there really is no great place to take shelter. I think that's part of it. Questions? Oh yeah, there's the certificate.
Thank you folks for joining us for PETOS. Once again, if you want certificate for CME, this is the process here on the screen. If you're here in person, you get it automatically. So we encourage those to come in person and join us. It's actually a great opportunity to talk to our docs directly. And we would love to have you in the room. But we're really excited that this is getting out to the rural folks that can't travel into Salt Lake, because that's really what we want to do, is get good pediatric information out to the entire state. We all want to do what's best for our kiddos. If you have any questions, email me at utah.petos@gmail.com. And I really do appreciate your feedback, and we're trying to make changes and improvements based on what you say. So please feel free to email for those quizzes, and we'll get them out to you by tomorrow. Have a wonderful day.